All right, good evening, everyone. We will get started. So I'm Melinda Irwin, and on behalf of myself and Hallie Moore, welcome to the Cancer Survivorship Committee meeting. And Hallie ordered up some food for us here, so make sure you grab some in the back there. And thank you for sticking through the day and being present here tonight. We have an exciting agenda ahead. We're going to just briefly start with just an introduction again as to our committee goals. So if you want to go to the next slide.
Sorry, I was telling people to put stuff in the chat.
So myself and Hallie. Okay, so I always think it's really nice when the 5 NCORE committees really share what their sort of areas of focus are so that we can all sort of better understand that, and therefore the members can know which committees to consider submitting concepts to. So in the Survivorship Committee, we think our area of focus is prevention of long-term effects of treatment, so cardiovascular, infertility, immunotherapy toxicities, and sexual dysfunction. The second bullet, reduction in comorbidity and improved cancer outcomes, treatment adherence, body composition, biomarkers, and patient-reported outcomes, with specific focus also on exercise and diet interventions and other behavioral or survivorship interventions. The third area of focus is health disparities, and related to our invited speaker today, to really make sure we're moving forward concepts on this topic of how to improve cancer care equity and reduce cancer disparities. The fourth, mHealth and technology in cancer care delivery, and then expanding beyond the common cancers. We often tend to get a lot of concepts in breast cancer, but making sure we're looking at some of the understudied and more rare cancers, as well as metastatic survivorship issues. All right, so now to our guest speaker. We are delighted to have Dr. Melissa Simon here today to share her research with us. She's the Vice Chair of Research in the Department of Obstetrics and Gynecology at Northwestern Feinberg School of Medicine. She's also the Professor of Obstetrics and Gynecology in the Preventive Medicine and Medical Social Sciences. She holds a number of director positions and is also founder for the Center for Health Equity Transformation and the founder and director of the Chicago Cancer Health Equity Collaborative. Also at the Feinberg School of Medicine, she is the Associate Director for Community Outreach and Engagement. And for many of you, I think you know that NCI in their Cancer Center Support Grant requires a focus on research in your catchment area. So I'm not quite sure what the catchment area is for Northwestern, but in doing that, making sure there's community outreach and engagement. And this has probably been for 5 years now that NCI has sort of mandated this. And I think it's just revolutionary and so incredibly important, and really is going to help move forward equity in cancer care and research. So I'm delighted that Dr. Simon is here to share with us some of her research and other thoughts and vision for this topic area. Thank you.
Thank you so much. Thanks y'all for staying this evening on a Thursday. It is warmer in here though than outside. Sorry, I didn't conjure up the best weather for Chicago, but at least there was sun. Just to answer your question, our catchment area is a 9-county catchment area, which includes Chicago, which is the 3rd most populous city in the United States. So we comprise about 80% of the entire Illinois population with our catchment area. And so there's some almost rural and a lot of suburban and then very urban areas across the catchment area, very diverse. In any event, let's start. So I am hopefully going to present just kind of like a buffet of the sort of what I help lead at Northwestern, and kind of some concepts, some definitions, because I never assume anyone is on the same page with me in the room. So First and foremost, and I'm sorry if you were at the Patient Advocates Committee meeting yesterday morning and heard some of these slides, but I promise you there will be different content in the second half. Architecture and design really matter. We learned this animal cell model, right, in grade school at one point, or high school. And we learned that each of those organelles have a role to play. And they've got to be in an environment that is conducive so that they can thrive and play that role well. And so that orchestration of the entire orchestra of the cell organelles and content actually creates a symphony, right? That's really important. And that's critical to everything we do with respect to a health equity lens. And when we're talking about cancer survivorship, when we're talking about research, when we're talking about cancer control, cancer prevention, the whole 9 yards, right? Definitions are also really important. So even though I am representing, or this picture represents an organic structure, a tree, inequities and injustices are human on human. And so it's really important to understand that I'm just using this as a symbol and a way to explain the way I think through the definitions. So inequality means, in the upper left-hand corner, that something is fundamentally bent. Okay, in this case, it's a tree, but again, it's human on human created. There is a structural issue, and it could be in a policy, it could be in a practice, it could be in how we deliver healthcare, how we have cancer survivorship programs in some areas of the country and not others, and why some people get access to some programs and not others. It could be anything. It could be a search committee for faculty or an admissions committee for students. Something's bent, and it's fundamentally advantaging one population or groups and actively disadvantaging other population and groups, okay? In the upper right-hand corner, I hear this a lot, but we're equal. And a lot of what we say, I'm not racist or I'm not this, it's because we think everything's equal. Everyone has equal opportunity in the United States of America. But if that structure, the underlying structure, the tree in this sample example, is fundamentally bent, then equality doesn't work. Because if you give everyone the same lift, you're still fundamentally actively disadvantaging some who can't get the apple from the tree and actively advantaging others who can easily reach up and get that apple. So in the lower left-hand corner, the word equity is important because what equity implies is that you acknowledge that that structure, process, practice, search committee, admissions committee is fundamentally bent. And so we have to give everybody a different lift or different type of supports or set of supports, tailored, precision, et cetera, to get to that goal of getting the apple. But where the work really needs to go with respect to health equity research, programming, everything we do, is really asking the fundamental questions of being able to identify where the trees are bent, where are the structures bent, and actually seek to unbend those structures or blow them up or unroot them and plant new ones. So those are important definitions. That's the way I explain equity and justice to all. So in order to do this, right, the late Congressman John Lewis always said, you got to look under the hood of the car. So it doesn't matter if you drive a Tesla fully electric car with a frunk and nothing in that, right, under the hood, or any kind of car in between. You gotta look under the hood of the car. You gotta look to see where the processes are bent, because they're everywhere, right? And they're related to gatekeeping, okay? So if you think about it, everything we do, whether we submit a grant to NIH or some other entity, whether we're trying to propose a concept in SWOG or another a research base, or getting a protocol reviewed or a journal manuscript submitted, whatever it is, there are gatekeepers at multiple layers along the way, right? And that gatekeeper, right, has some rules and biases and principles as well, which could be bent, or the rules that they're following could be bent, right? And that then adds up on layer on top of layer. And all of that gatekeeping then puts what we see out there as the final product, that phenotype, so that whatever gets published in certain journals versus others, who gets into JAMA New England or Cancer versus others, who gets the NIH funding versus not, right? All of those layers of review and gatekeeping are really essential, but they're part of these structures under the hood that you got to look at and seek to identify them. And we can all do this at all levels. You don't just have to be a high level leader to do this. The other part of health equity and principle, these also, while diversity, equity, inclusion, and health equity are separate, they have similar concepts and similar lenses to look through and to identify. You still in DEI have to look under the hood of the car, examine the processes. All of those things are super important to that. But what we put in to whatever the program is or the research at the bench is what we're going to get out of it, right? So who participates in clinical trials, for example, will then be that's how the results will be generalizable to, right? That's who the populations that will be generalizable to. So if we don't have diversity in clinical trials, right, how appropriate will those results actually apply to a diverse group of patients later on, right? And we see this a lot. We see it, I'm an OBGYN, we see it in GYN cancer a lot, right? Endometrial cancer is a great example, right? We have lots of clinical trials for our most used endometrial cancer treatments, but very few Black women have participated in those trials, right? So how, and people of African ancestry. So how can we actually say those treatments are applicable? So oppression and racism are fundamental causes of disease and are baked into our systems and institutions. Oppression and racism kill. And those bends of the tree are structural racism or structural systems of oppression that operate at multiple levels. And so how oppression and racism affect health. So this is from Dr. David Williams at Harvard and in Health Services Research 2019. And I just think it's a really good pictorial of how racism and experience of racism over time and also systems of oppression, because there's intersectionalities that happen with multiple identities that get under your skin and actually do impact many things. So if you look at the top, the house that racism built, you've got different types of racism: institutional, individual, cultural. And then in the basement of that picture, you see how racism gets into the skin and impacts psychological responses, biological processes, behavioral responses, healthcare use responses, individual and collective responses. And those all collectively impact health outcomes. So you can see how complex the interplay of all these bent trees have on then the outcomes that we see. And then, again, we have to ask ourselves, well, how did we get here, right? How did the phenotypes of persistent cancer disparities across every type of cancer, pretty much, and across the entire cancer care continuum, how did we get here, right? Despite billions of dollars over decades from NCI funding and other funding entities for research. How did we get here? So let's consider environments. Now, you all know this, right? We have a deep and long history of oppression and slavery, racism, and discrimination. And COVID-19 has exposed existing health inequities and exacerbated across the board. But the other thing it did was there's syndemics going on. It's not just COVID. There's disinformation, and there is this very strongly divided country that we have, almost 50-50, on comfort or trust in science, comfort or trust in health, healthcare, medicine. Now, we have earned in healthcare and in science, we have earned distrust for many populations based on centuries, right, of abuse. And it's going to take us not overnight to unbend all those trees. And it's a process, it's an iterative process. So it's important to understand that history. But one of the biggest things we need to focus on right now is the rampant disinformation that is running large and wide throughout the internet, throughout Facebook, YouTube, TikTok, WhatsApp, all of these different communication strategies. Super important. And what's more pressing right now is it's not just running rampant in English. It's actually more pervasive in Spanish and even more in other languages, because YouTube and Facebook, even though they say they're editing some of the health disinformation, it's only in English. They're not editing in another language. I can prove that with just the reproductive justice stuff and abortion right now. There's rampant disinformation across languages, but especially in Spanish. And that's a problem. That's going to promulgate the most vulnerable populations to be even more susceptible to health inequities, be even more reluctant to engage in cancer screening or care. So this is from the National Academy of Medicine 2017 Communities in Action Report. A lot of people talk about social and economic and political determinants of health, environmental as well, or social needs. And people are collecting these data. It's sexy to collect these data in your electronic health record, whether you're a community clinic or a hospital. But the issue is what do we do with these data? We know that we're not really going upstream in our health systems very much, with rare exception, to actually try to address the unbending of the tree, the structural racism, the structural oppression that's driving the phenotypes that got us to where we are right now. In Chicago is a great example, right? And in Baltimore and Philadelphia, you can take the Green Line, which starts down here a few blocks away on Lake Street, and literally in a few stops, in about 6 minutes from here, where we have the highest life expectancy, right where we're standing in this little community area, you go about 6 minutes west, straight west, and it drops like by almost 25 to 30 years. That's egregious. That's terrible. This is human on human made, these structures, right? This is based on years of redlining and disinvestment in the west side, which is directly straight west on that Green Line, and the south side of Chicago. And all of that disinvestment then, drove these factors that are required for health, right? We know these are required for health: good education, right? Help with health literacy, right? Good transportation, access to care, the public safety, green spaces to move around and do physical activity in, and just to enjoy and to decrease stress, housing, right? All of those disinvestments and policies and practices that were focused on structural oppression drove these factors to be absent or poorer in those neighborhoods. You can see it in Baltimore, you can see it in Philadelphia, and many cities around the country that are highly segregated. So it's like in Chicago, there's 2 different cities and 2 different cliffs. So why are the green people starting at the edge of the cliff and don't have the advantage of a fence or a safety net or an ambulance with GPS that works, gas in the tank, tires that aren't popped? Whereas the yellow and orange people on the other cliff start further back from the edge and have all of those advantages, those protections. So, we talk about at-risk populations. I don't like to use that word, systematically excluded and oppressed, and that underlying structures and systems matter, as I said. Now let's look at the research pipeline. This is a research base, SWOG, and we talked about survivorship research. We got to understand, so look under the hood of the car. There are numerous gatekeepers in the entire research gatekeeping, for the entire research trajectory. There are numerous gatekeepers, right? It starts with the funder. So who sits on the board of the funder that dictates what the funder will focus on? Who decides what funding opportunities become available? And who puts the words to paper of what is going to be required of the applicants to those funding opportunities? How does that content come about? Who decided that the NCI's Cancer Center Support Grant now has two important components, DEI, diversity, equity, and inclusion, and community outreach and engagement? And who decided that community outreach and engagement was one of the major score driving factors that was going to help determine the level of funding you got if you were a comprehensive cancer center, right? Those are critical, because if we didn't have those embedded in that RFA, let me tell you, community outreach and engagement, when I lead, be underfunded even more than it already is. And there will not be DEI today. The cancer center director would not be thinking as much. I mean, maybe they would think, some of us, if we were directors, we would think about it. But we wouldn't be like really, strategically and intentionally examining DEI at all levels across the cancer center. So how we design, or how NIH and others design funding structures and funding opportunities and those requests for proposals, that is what you all as a PI will do to write the grant. Oh, they asked me to have a community advisory board. I'm going to have one. Not as many investigators would naturally just put community as partners and funded as part of subcontracts or multiple PI structures at the table if it wasn't required. And if you don't require sex as a biological variable or inclusions to be addressed as part of the scoring rubric for NIH, we would have less diverse studies, even less. There already are relatively fewer diverse studies than there should be. But because now the inclusions of what age groups, what identities, racial, ethnic, women, all of those things are required and part of the score driving components. Again, I hope you're understanding how all of these trees can get bent and accumulate on top of each other and really drive why we see what we see in the world today, especially in the United States of America, with respect to inequities. And then the scientists, who's on the research team and how did they get to be a PI? Who gets to be a PI? Who gets to be a PhD? Who gets to be an MD? Who gets to be a nurse? Who decides that, right? There's schooling, there's that whole other pipeline. And again, a whole nother set of gatekeepers. I think you get the gist of what I'm saying. Now we look at the actual study in the clinical trial protocol. Who reviews that concept? And is there a rubric, like we talked about yesterday in the Patient Advocates Committee? Is there a rubric or a checklist of the sorts? Again, checklists are really important to safety, like in aviation. They're important to safety, like what I do in the operating room. Checklists are essential. So why don't we have checklists in other places, like a rubric, a scoring rubric, that is based with an equity lens, and really trying to review the concept up front before it goes anywhere further in the pipeline. And then another review at the protocol level, right? Before it goes anywhere in the pipeline, because that protocol can make or break who gets to participate and who doesn't. Let me give you some examples. Exclusion and inclusion criteria. Those two things can actually make or break who gets to be in the study. And like I said earlier, who are you going to include, right? And what are you going to do to make sure they're not accidentally or inadvertently excluded? Like blood pressure. How many of your protocols in SWOG require blood pressure control? Now think about it. To get blood pressure control means you have to have had a primary care doctor or a primary care medical home, a nurse practitioner, physician assistant, whomever, somebody who identified that you had high blood pressure, somebody who then prescribed you first a diet and tried to work with you on all of those things first to try to get your blood pressure under control, and then to give you medication and manage that medication. That required you to get to the clinic multiple times. It required you to be able to have a pharmacy, right, that was accessible, and a medication or set of medications that were affordable, and perhaps insurance that covers it, right? And then the literacy level, the health literacy or the education and the trust to actually engage with that care, right? Despite perhaps experiencing discrimination either personally or through your family or friends or loved ones. So all of those issues play out in that inclusion and exclusion criteria. So why aren't we then, for example, unbending the tree by, okay, here is a patient that's coming to our cancer center who does not have their blood pressure in control, but could, right, with the right care, if we plug them into the primary care team for 6 months or so, and they could still be a potential good candidate for this clinical trial. How many people do that? Unbend the tree. There's so many ways to unbend the tree, right? And that's why I'm not calling it straighten, because straighten implies it's just one way to do it. There's so many ways to unbend the tree and to rethink what we can do to try to aim towards health justice, to try to unbend that tree. But people need to see it and ask the questions and think about who's the gatekeeper, right? So the person or people writing the protocol, gatekeepers, people reviewing the protocol to accept it, gatekeepers. So other things in the study protocol, how many visits, and can the visits be local as opposed, or telehealth, as opposed to in person all the time, right? Things like that. Pharma companies are thinking about those things. Community-centered trials, unstructured trials, right? So that is currently underway in many ways. And what are the roles of community and patient advocates? And not just using the word engagement, because engagement kind of applies, okay, I have an advisory board and we'll just vet it, but really centering patients, communities, their loved ones, or caregivers, especially in the survivorship world, caregivers are super important. So really centering. And then the research findings. So there is a whole nother pipeline, right? It's called the publication pipeline that is fraught with gatekeeping. And I know this because I was a part of the JAMA debacle a few years ago. And I then became part of the editor-in-chief search committee. And, again, trying to think through the entire research pipeline, publication pipeline, how journals first review manuscripts, right? What are the criteria? Nowadays, many journals have a DEI person, right, to look through and kind of thumb through for those issues up front. And then who reviews those manuscripts, right? And how do some get in and not others to certain journals versus others, right? And there's a lot of research on this, but it is important. There's true publication bias, because when you think about it, you got to think not just to who gets into those journals, but then how does the end user, meaning community oncologists, primary care practitioners, patients themselves, people themselves, community themselves, how does the public get a hold of that knowledge? The media. Media. So, the media tend to grab onto the hot topics that are going to give them more views, right? Get more people watching their show, their network show. So thinking through that's yet one more huge set of bias and huge set of gatekeeping. And then also nested within that is the politics of the communication itself and the communication of science, right? So it's complex. I don't mean to depress you, but I'm helping you maybe turn on a light bulb in some area that you could probably go forth and perhaps unbend a tree. So we all know this, diversity matters in clinical trials. And we do know that, Black or African Americans are about 13% of the United States population, but only about 5-ish% of the clinical trial participants. And Latinos are about 18% of the population, only about 1 or 2% of the clinical trials. And even the physician workforce, those bar graphs below, by race and ethnicity, and the scientists, so NIH-funded investigators, do not match the population at all, right? And we know that there is a huge advantage when you have diverse identities around the table, when you're designing research, when you're reviewing research. Huge advantages when you have diverse people taking care of patients. Again, diverse scientists tend to focus on issues around health equity, or or at least bring in samples. If they're bench researchers or translational researchers, bring in samples from multiple populations as opposed to just one. And then access to care. So access to care has a lot of dimensions that I've already spoken about, but I'll just walk you through it. It's more than just insurance, right? Risk factor in the upper left-hand corner, risk factor management, quality and consistency of care, receipt of guideline concordant care. Now that one is, really important for survivorship, important for cancer prevention though. I served 5 years on the United States Preventive Services Task Force. And let me tell you, I was part of all of the racism stuff, but also importantly, part of, the language we use in the cervical cancer screening guidelines that came out in 2018 to be more person-focused and more gender neutral, and like persons with cervixes, for example. I was a part of the colorectal USPSTF screening guidelines and the lung cancer guidelines. And it was really important to have those lenses at that table and have the voice, because it was very easy to see how the guideline creation process or the recommendation making process could go off track and be bent. And so we did a lot of modeling, a lot of back and forth iterations to get there. But when you look at the actual implementation of guideline or recommendation concordant care, it is not the same across the country. It's not the same across the city of Chicago. And I'll get to that in a minute with the Chicago example. Lower left-hand corner, there's the training, there's lack of diverse workforce, like I mentioned before, biased mental models, lack of cultural humility. On the far right, lower corner, there's stigma, distrust, right? Things that I've mentioned already, experience of discrimination or racism from either personal or from family or community or generational, because again, this is built on centuries of abuse. And then the middle circle, the financial toxicity, the out-of-pocket costs that people don't think about for even clinical care community sites to open trials, cancer clinical trials, or patients to actually be involved in a clinical trial. Those out-of-pocket costs, like transportation, right? Having to pay for food in your cancer center that costs a lot of money if you have to be there all day because you're part of a clinical trial that requires a full day visit. Who's going to pay for the food? Right, our restaurants at Northwestern are expensive, except for maybe Subway, but that's still relatively expensive. And then the upper right-hand corner, the social determinants of health literacy, and location, and all of those things. So I'm an implementation scientist, so I'll walk you through a little bit of implementation work we do in the Cancer Center next. This is one of many implementation frameworks. This is the consolidated framework for implementation research called CFR. And again, these systems and these bent trees can operate at every level of that framework. So having the intersectionality of understanding health equity and implementation science at the same time is really critical if you're trying to do an implementation science study. I think it should be mandatory, but I haven't convinced all the implementation science folks that it should be mandatory, but it's important. And then centering community and people with you in this framework is really critical as well. So this is not meant to be read, but if you're looking at design, You can go to the website. This is from the National Academy of Medicine, Roundtable on Obesity Solutions. We did a series during COVID of webinars to really address using a systems approach and implementation approach and thinking like in a design thinking way, what would it really take to get rid of the obesity epidemic? And this is what we came up with. It is a big sticky issue, right? But important to address. But you cannot, not one silo can solve the epidemic of obesity, not one silo, right? And it takes a lot of different parts and moving parts and that are interdependent. Again, just like this animal cell, right? Everybody needs that environment to thrive. So the right policies and practices, thinking about getting, unbending the trees, and so that everybody can do their job and then do it collectively so that orchestra can have a wonderful symphony. That is the kind of thinking that's required, right? And that's the kind of work that's going to move the needle on health disparities. So here's an example. It's not as crazy as the obesity one. Here's the breast cancer disparity. Okay, this is Chicago, okay? I already talked about the structures and the racism and the design of Chicago with the most health inequities lying predominantly on the south side and west side. It doesn't matter, pick any disease, any type of cancer, anything, any type of screening, it's worse on the south side and west side than it is in the rest of the city. So in the early 1980s, if you look on the left side of that graph, you'll see the black-white 3-year age-adjusted aggregate breast cancer mortality rates. And they're about the same, okay? However, as we move to the right on that graph, move towards 2007, the line that's magenta are Black women and the line that's gray are white women. And you see something happening in the 90s, right? Technology of mammography, access to care, research starting to flourish. Remember, we have 5 major academic medical centers in our city, including Northwestern and University of Chicago, the 2 comprehensive cancer centers. So we get lots of money collectively across the city to study breast cancer, a whole lot. And then by 2007, Black women in Chicago were dying at a rate that was 62% greater than white women. And no, it wasn't just about triple negative. No. All right. So what is this? We looked at, then we said, oh, New York's got to be just as bad as us. No, it was like 27% difference. United States was in the 40s, mid 40s. So again, what's going on? Are Black women in Chicago and white women in Chicago different than Black and white women in New York? No. So what was going on? So we did an extensive amount of work. And we took this social ecological model and we looked at interpersonal barriers, community, health system, and public policies. And we did a lot of iterations on, so we worked with systems engineers and literally did environmental scans across about 30 clinics and mammography centers across different neighborhoods in Chicago. We followed women from the time they came into the door to the time they left, and we documented all the processes, and we fed them back into the clinics to improve quality and consistency of care. All right, that's the first thing we did. We had to get the baseline and figure things out. So basically what was happening is that many mammography centers, especially on the south side and west sides of Chicago, were not giving results back. They couldn't find the patients. So women were getting some women were getting mammograms and not getting the results back because they thought, well, they weren't getting a phone call, so it's normal. And even to this day, there's a lot of those barriers still at present, the challenge of contacting patients and getting their results back, but it's much better. Okay, so that was one part of the problem. The consistency in reading. So the people who are reading mammograms weren't consistently doing it in some centers at the standard level of care. What was the gold standard? So there are a lot of BI-RAD 0, there were just misreadings. So we had to fix that too. And then there was people not following up, and there was a need for patient navigation to really help women not get lost to follow up. But once they were diagnosed with an abnormal result, how are we going to get to a diagnostic resolution of that abnormal result? And if it was cancer, how do we get them into cancer and treatment and all the way through? So we did a lot of navigation work, implementation science and quality improvement work, and a lot of advocacy and policy. We wrote several bills that became laws, one of which, the first one that was the most important one, basically raised the reimbursement rate for Medicaid, the Medicaid rate to the Medicare rate, the higher rate, in exchange for quality data. So then we started to collect quality data. So there was a carrot and a stick, so to speak. So patient navigation is an evidence-based intervention. I was part of the original trials. And we know it's an evidence-based intervention. We also know it's a health equity integrated, embedded intervention. And it's not one size fits all, right? And that the challenge of patient navigation is that navigators are really, I love navigators, don't get me wrong, but they're Band-Aids because we're not learning from them. We should be learning from them. Like people are talking about, the learning health system and all this stuff. We employ navigators or promotoras or community health workers, but we don't necessarily follow the patterns of what they consistently do with certain phenotypes of patients. And we could learn a lot from that and feed it back in. Think about AI, right? Machine learning and all those other data science approaches, and feed it back in to fix or to unbend the trees across our health system, our healthcare delivery, right? Learning health system, patient navigation, really trying to think about how do we move that forward? And then how do we integrate social determinants of health, understanding what patient navigators do, right? They really do connect people to different health and human services that wrap around, right? They connect community organizations to each other. We've proven that in some of our studies in the larger suburban areas of our catchment area. Our navigators were deployed across an entire county, the second largest county in Illinois, DuPage County. And what they did was connect organizations to people of color who needed care, but also they connected the organizations to each other to work together because they weren't working together before. And so it created more of the wraparound effect that's required to help support the social determinants of health, in addition to helping then facilitate care follow-up and trust. Okay. So the other thing that we did, here's some process measures. Process quality improvement, is that with these systems engineers, we also took this idea of checklists that I mentioned earlier and safety. So we created a checklist, literally, of all the things. This is just one example. We also have it for survivorship and primary care, graduating from cancer treatment back to primary care medical homes. We have a checklist for that. So we call it the 4-hour sequence. And this has been published before. And this basically looks like a Gantt chart for those of you who write grants. And basically what we did is we put on a cardboard or a piece of paper, cardstock, and literally drew out all of the things that you as a patient with breast cancer, if you were gonna get surgery first, what you would need. And so you and your caregiver or your loved one or your family members would be all on the same page with your healthcare team, because believe it or not, we may call ourselves a healthcare team, but we're not a team. We're not a true team. It becomes really siloed, like your radiation oncologist, your medical oncologist, your surgeon, your cancer survivorship support, your social worker, your dentist, your ophthalmologist, everybody, cardiologist, whatever, just the whole list are really, even though we say we're a team, we're not kind of connected with who's on what base and who's doing what, right? But this piece of paper, this helps actually convene everybody. This version was not electronic, by the way. But what this does in terms of embedding equity is there's check boxes. And if a box isn't checked, it empowers somebody, even with the lowest levels of health literacy, to ask, why isn't this box checked, doc? Doesn't matter what the box is. Why isn't it checked? Right? So for people who don't read, right, or have a lower health literacy, like I said, this helps empower them and their caregivers and loved ones. And on the back of the piece of paper or cardstock, there's a list of all the phone numbers, phone a friend. So it's like taking these concepts of patient navigation and trying to scale them and embed them into both the care team and the patient, right? Thinking about it, again, implementation science is like the engineers of healthcare delivery, so to speak. And so that's what we were doing with these different approaches. The other thing we do a lot of is, and you heard it earlier, Chicago Cancer Health Equity Collaborative. We do a lot of collaboratives. A lot of community partnership that's embedded in everything we do. And this was, we're in our, oh boy, 7th, 8th year of funding for the U54, which is a NCI SAPACHI Cancer Health Disparities Center grant that unites our Comprehensive Cancer Center at Northwestern with 2 minority serving institutions. We're one of only a few trios funded in the United States. We're with Northeastern Illinois University, which is a predominantly teaching university, and University of Illinois at Chicago. And we wrap around to do we get together to do research, training and education. We have a very large and well-known undergraduate and community college summer program that's intensive to learn research, health disparities research, and to become a cohort and learn from community partners and leaders, as well as faculty from across the institutions. And then they get launched into individual laboratory experiences as they move through their trajectory, their future. So it's a multi-step program, highly successful in launching people into healthcare careers, into science careers, medicine, nursing, occupational therapy, et cetera. We have a lot of community forums, and yes, the beautiful woman on the far right corner is Yolanda Ross from The Shy, from Showtime, The Shy. And she's partnered with us over the last few years because her character was experiencing breast cancer. And so what happened is I thought it was a prank, but her publicist had reached out to me a couple times. It took a few times because I really thought it was a prank. And she had wanted to learn and follow me about helping her get ready for her role, for her character. And I said, no, I'm not the person to follow. I'm just a clinician. You have to get connected with these local community organizations. So I connected her with several community organizations. And over time, we worked with the community organizations to help her prepare for the role and survivors of breast cancer. And that was really critical. And then what happened is we were able to get donors to then join with Ms. Ross to then donate to the organizations with which she worked. And so instead of me at the Cancer Center pulling money from those donors, it was more important for me to help connect the philanthropists to those community organizations. So that's the type of work we do. I know I'm trying to integrate all of this into one talk. One other thing we do, so we have community scientists. Some people call them citizen scientists. I don't like that name. Our Latino community, of which I'm a part, citizen is just not the right word for this. So community scientist team that weighs into a lot of things. And I think one really important example of what we're doing now is that because of the structures of how Chicago was designed, with the poorer neighborhoods clearly having higher metal exposures from the design of where the highways are, so diesel fuel and emissions from trucks that plow through our west side and south side neighborhoods, along with factories and waste dump sites and things like that. So we know that in cancer research, certain treatments are not helpful, or not helpful, or do not work well if a patient has a high metal exposure, And so what we're doing now is we're swabbing cheeks. So we've spent the last few months in summer fairs and tabling at multiple different events across multiple community areas in Chicago. And we have people who are volunteering to swab their cheek, and we're actually analyzing them for metal exposure. And we're going to start with that because our community scientists were like, this is egregious. What can we do about the environment's impact on cancer disparities? And so this is how this was organically born. And so we're full steam ahead. So we've got health equity scientists, we have community engaged researcher experts, implementation scientists, and epidemiologists, but also importantly, the bench and translational scientists who are going to do all the metal analyses. And that's going on right now. And we're going to go out into more communities and more events and continue that. Another thing we do is we partner with the Chicago Public Libraries. So we have a few National Library of Medicine grants. And we started with the Health for All platform because that's built on literally a decade of work from the original GMAP and BMAP work on how to improve clinical diversity in clinical trials. We're also, this work has now been the basis for a newly funded, as of last month, one of the CUSP2 clinical trials, the NCI RFA. There's, I think, 5 sites across the country that have been funded to test different approaches to improving racial and ethnic underrepresented minorities in cancer clinical trials. So we're one of the funded sites, and that work has led to this. So with all of that work, part of the story is that we were able to reduce the Black-white breast cancer mortality disparity as of 2017 and 2018. So before the pandemic, I don't know what these data are now after the pandemic. Well, we're not done with the pandemic, but right now. But the Black-white mortality gap is still not good enough, but it's 36% as opposed to the 62%. But it took all that work. It took multiple people, and let me tell you, it took lots of media, lots of communication, lots of strategic media, because let me tell you, we're called the Windy City because of politicians and politics. It is not because our wind sucks. It does, but our politics are hard, right? If the aldermen who rule the city and all these different community areas want the data to magically go away, well, the data can't magically go away, right? Without unbending the trees. Make a policy, unbend the damn tree, right? So again, media is important, and telling the story is critical, and collecting data in a scientifically rigorous way to stand on that science and tell the story, because those data belong to the people, and the story of the people need to be at the table speaking, not us. I'm almost done. Workforce development, very important. We have lots of different programs that we do that are connected to Lurie Cancer Center and across the institution. And it also, so the Chicago Cancer Health Equity Collaborative is a really important one. We have a T37 from the National Institute of Minority Health and Health Disparities, and that basically trains anyone from an underrepresented background in any subject, as long as there's a health equity lens, from levels of undergrad all the way to postdoc fellows, about 10 slots per year. And then we just received a few weeks ago one of the NIH FIRST grants. And so that is, we're the first in the Midwest to receive one of those, and that it was a $16 million grant to help hire 15 faculty, early career faculty, on the tenure track from underrepresented minorities over the next few years. So that will help also our cancer center, because it's 3 foci areas: cancer, cardiovascular, and brain, mind, behavior. So in conclusion, we need to be strategic and intentional. You got to look under the hood of the car and make that good trouble, and to ask why, to understand who is the gatekeepers and how can we unbend trees. And the onus is on all of us, but really it does start with the leadership, and having leaders who have your back as you do this work is really critical, and who are willing to listen. even when what you have to say is contrary to what they think or want to do. It is about the we and not the me, and there's my contact. Thank you so much. Oh yeah, I'm gonna stay here and answer questions and get more food. Everybody's tired. I exhausted everybody.
I was just gonna say, I don't know if you can hear me from here, but from the chat, just an appreciation, thank you for this, all excellent points. And also wondering whether the slides will be available.
the incessant word. Yeah, some way, shape, or form.
So whatever you want to share, you can share with Melinda and me, and we can disseminate those.
Okay.
Hi, absolutely fabulous talk.
Thank
I
you.
think everybody's just probably spellbound, even more than tired, so bravo.
I didn't mean to exhaust
Thank
everybody or depress everybody. There is hope. It can be done. I just showed you.
Yeah, that message came across loud and clear, so well received.
Thank you.
One of the areas that, my name is Marie Bakaitis, and I'm from the University of Alabama at Birmingham.
I have great collaborators at UAB.
Yes. So one of the things that on many of our slides shows that, the reason for lack of enrollment is often on clinical trials of, especially in African American communities, is the mistrust and so forth. And yet there are many examples of studies that have been very successful, even at UAB, in over-enrolling in our trials. Mm-hmm. And the things that we found that were beneficial were, having navigators and recruiters who look like the populations that we want to enroll. And the point was brought home to me really loud and clear is that we don't necessarily ask people. We don't do enough asking of people from minority populations. And I think that that's a message to I'd like to know how it is that you have been successful in the asking, because I think that's one of the areas we sort of blame the victim, right? And say, well, we have all these great trials and they just mistrust us. So, and what it's really about is we didn't ask the people.
That's why we partner with the libraries.
So anyway, just appreciate hearing more of your thoughts on that.
Absolutely. We don't ask, and a couple of things. So that's one of the reasons why I started partnering with the Chicago Public Libraries, because it's there is research that shows that people trust librarians as one of the most, as the highest trusted professional in the country. Librarians, not physicians, not nurses, not teachers. Teachers are up there, and nurses are up there, but certainly not physicians. So trust, and the space of the library itself is safe. And so when you think about, if we're trying to deliver information in a trusted space, right, to help people be more comfortable, more receptive to receiving that information, and being willing to want to receive that information and to trust the person, the librarian, then availing information around clinical trials, dispelling myths, and all these modules that we have and programming that we have at the libraries is really critical. The other thing is that we just started this. This took me several years to convince my cancer center director, but very few cancer centers actually look at their own, under the own hood of the car and do, so I'm embedding 3 or 4 questions into the electronic health record for every new oncology visit. Every new patient who comes into our cancer center, I ask the clinician team, and it's whoever is on that team, it's probably going to be the nurse. I love nurses for this reason. And we're going to ask, was this patient offered a clinical trial? Why or why not? And if so, which clinical trial? No one looks under the hood of the car, looks in their own backyard. We're all out there going, oh, we need this fancy thing, we need a patient navigator. Well, we need to actually know what the teams are doing, and each team operates differently. So understanding that, again, the design, right, the implementation, how you do that. So we're starting that. That took me a while to get permission to do, but that is an important part of understanding that clinical trial diversity piece, which the COE is, community outreach and engagement, is supposed to help influence. We're not charged with it, but we're supposed to help influence it. I hope that answers your question somewhat. Yeah, absolutely. Hi.
Dawn Hirschman from Columbia. I spend a lot of time thinking about what we could do better to engage, and we have so many opportunities for training and opportunities for career development, and in SWOG about mentorship and really diversifying the clinical trials workforce, and trying to figure out how to get more people engaged. We've talked a lot about diversity supplements, and we're ripe for being able to do that. We have these big grants that people can write these supplements off of and do projects and learn more about clinical trials so that we can build this up. And we haven't been super successful at figuring out how to bridge the gap. Not that there's not desire to do it, but finding the right pockets, like reaching out. In our own institution, we also have, training at the high school level and everything else. And when we bring high school students and college students from diverse backgrounds into just spending the summer with our clinical trials unit, it's like they come out just sort of awestruck about the kinds of things that are being done. And so I guess I ask, like, what more can we do, to be better and to diversify our workforce?
Yeah, thank you for that great question. Really important. So again, like begets like, and having people on the ground who have lived experiences of, like myself, of coming through this pipeline and being told a whole lot of who I wasn't going to be and what I can't do, and I should not go away to college, and my research has no legs. That was what my current boss told me 17 years ago when I started Northwestern. I wasn't going to be allowed to be a Northwestern faculty. My research has no legs, and here I am. But again, having lived experience so that you have insiders that know how to navigate. You have people who look like the students you want to bring through and the diverse faculty and trainees that you want to bring through. So we have travel scholarships. So part of it is when we're growing up, some of us can't see at all that there's no way I will ever be at a Northwestern or a Columbia or a Harvard. No way. And there's no way I will ever get into medical school. I am bound to work in my family's restaurant, which isn't a bad thing, but I am bound to this because I see that, right? I can understand that. So when you have your program and you bring high school students into the labs or into the trials unit, of course, it becomes more tangible. So that's why one of our programs, the Chicago Cancer Health Equity Collaborative, is so popular and successful, because we bring them in, but then we don't drop them after that 8-week full-time summer program. We pay them just as much as they would at a job. We pay them minimum wage of Chicago's rate, because that's really important as well. You've got to pay them, and then we then bridge them into the next step program, and bridge them again. So we have like the LEAP program that follows, and then so they get into other labs or community teams or other teams, so that there's a trajectory and they see it, and we're helping them get through the trajectory, right? And so at the other part of this is we are surrounding them with people that look like them and come from similar backgrounds, so that they're not feeling alone across an entire city. Right, so they have the network. So by pulling them in across community colleges and the different institutions in the area, we are not just like Northwestern program. We are a comprehensive program. And so they build the network of near peers, which is really critical. And then they also work with the high school student program at Lurie Children's, Discovering Healthcare Careers. So they're pulling the high school students with them. So strong, powerful things. And then we have partnerships with, so in ECOG Akron, I'm the co-chair of the Health Equity Committee with Dr. Edith Mitchell at Jefferson. And one of the real wonderful things that Dr. Mitchell has done, of many that she's done, is brought National Medical Association into ECOG Akron for years. And everywhere she goes, and it's not just NMA coming into ECOG Akron, ECOG Akron's going into NMA. And we're adding with the new UO1, the CUSP to clinical trials grant, we're adding the Hispanic Medical Association and really trying to center more clinical community oncologists, because that's where most of our underrepresented minority patients go, and trying to bridge all of those different layers together. So there's multiple things to do, but it really does, like, I don't know, for those of you who have children, the best way to childproof a home is to actually get down on your hands and knees and crawl around at their level. And I'm not saying get down to their level, but what I'm saying is a lived experience. It's like, you can't childproof a home unless you're a child and know the lived experience of what a child going through a child's brain, and like they like to touch things and put fingers in holes and eat things and whatever it is. But you have to understand, you have to walk in those shoes, and that's why having a diverse workforce and a diverse team is so critical. It's so critical to everything we do. And so those are just my thoughts. I'm worried about time. I'm probably.
We'll take one last
Okay.
question. Thank you.
I see this clock now counting the other way.
Thank you so much for your talk, Nicole Kudera, Kirkland, Seattle. First of all, congratulations on probably the most extensive and comprehensive assessment of disparities in the various levels I've seen. And I've seen quite a few talks, so this is very remarkable.
Thank you.
Two questions for you. As you mentioned, the tree has been bent, chronically, severely. What are our obligations to maybe also formally institutionalize unbending the tree, for example, quotas? There are wonderful qualified African-American individuals and Native Americans that had the biggest disadvantage, that are even competing with international medical graduates, which I'm one of them. And, I've checked the boxes in my country to get to the highest level, right? To get to those 25 medical students who get invited to study at the university of choice in the UK. And they're competing with me as well, and not just the best of the best in the US. So what are our requirements for quotas? And what are our obligations to, as most of these disparities are really financial, educational, opportunity disparities, to really sound the alarm, and not just to research, but really to engage policy and really sound the alarm, to stop focus on just research, but really change policy.
Yeah. Ooh. How much time do I have? Quotas, I don't think it's about quotas. And I think that word kind of, so there's just certain words that we shouldn't really stick with. I think it's more, why not, right? Why not have a diverse team? And what is it that has brought us to a not diverse team, or a not diverse patient population, or a not diverse clinical trial participant, whatever it is. And so I think framing it that way, instead of quotas and having 5 of this and 3 of this and 1 of this and 6 of this, right? It's there is a business imperative, and there is a productivity imperative, and there is a better research imperative and a better clinical care imperative when you actually have a diverse workforce. It's tested and studied across many different entities. So why not is more the framing. And that there are a lot of programs now, like the first grant initiative through NIH, through the director's office, and NCI is a major funder of it, is really an important step towards doing that without quotas, right? It's specific to figuring out how to transform the institution and how they do business with respect to reviewing, getting people to apply to faculty tenure track positions, how they review holistically the dossiers of underrepresented minorities and diverse faculty applicants, and then the whole process. What questions are said in the interview, how is the interview conducted, the rubric, the checklist, and then all of that onboarding and retention and helping people to thrive and trying to change the culture to allow everyone to thrive. Right now, the ecosystem of most universities is not helpful and does not allow every single individual to thrive. It's actually harmful to some. And so when we get to that level, we shouldn't have to think about, well, what's the quota? How many more African-American or people who identify as Latino or Native American Indian, how many more do we need to be, I don't know, a DEI star institution? It's not about that. It's about, there is an imperative that we can do better in healthcare delivery. We can do better in research. We can do better in everything we do if we actually are more inclusive and understand that what got us to where we are today, what got us to who is on our team, right? If it's more homogenous than diverse, what got us there are all these darn bent trees. And what got us to our research portfolio or our clinical trial participants, it's all these bent trees. So that's why I wouldn't do that. And then the one thing about policy is people really do need to weigh in and be more civically engaged. You have to vote, but unfortunately, voting is not accessible to many underrepresented communities, especially with all the laws that are going on and gerrymandering. But we do have to vote because that's really important. But we have to be civically engaged, and that means weighing into policy when it's bunk. I'm part of the National Academy of Medicine current consensus study on federal policies that promote racial and ethnic health disparities. That report's going to come out probably later in 2023. We're in the throes of that right now. But that's going to be a really important report. And we're basically doing an autopsy of all the different policies and how they're designed with respect to what happens with respect or lack of policy with respect to racial and ethnic disparities, health disparities. All right, I better go.
Thank you so much. That was fantastic. And I think as we all work on our studies and development, it's really important to continue to think about how can that study help to unbend the tree. So I love the metaphor. Yeah. And then it's my pleasure next to introduce Lee Jones, who is our Survivorship Committee patient advocate and is going to share some of what he's up to.
Thanks, Hallie and Melinda. It's a pleasure to be here, and I prefer this time slot to the 7:30 a.m. time slot. I can tell from the audience here that that's not typical, because normally the place is pretty crowded. So, I kind of apologize. Many of the people here have probably heard this over and over again. I was thinking, well, you need to hear things 3 times before you can remember them. So maybe this will be the 3rd time today you've heard this, so maybe you'll remember it. So I want to talk a little bit about the patient advocates that work with SWOG, work with all of you. And, everyone says, oh, patients are the most important. But I think SWOG has really stepped up to the plate. In fact, much more so than the other 4 cooperative groups, and certainly much more than most organizations. A lot of that's thanks to Dr. Blanke, who's really been very supportive, and to Rick Bangs, who's been the chair of the Patient Advocate Committee for the 5 years I've been working as an advocate with SWOG. And when you consider patients as being very important, that really leads into diversity, equity, inclusion, because we all know that most of the patients don't look like me, and they don't need the same things that I needed. And so that really does factor in with What we're done on the Patient Advocate Committee is we try to bring in as much of the diverse patient population as we can. And Dr. Simon mentioned lived experience. She was talking more from a researcher and clinician point of view, but we're talking about it from a advocate point of view. All the members of the Patient Advisory Committee, or known as the PAC, have lived experience with cancer. For me, I'm a stage 4 colon cancer survivor. Some people have been caregivers. Some have been for their spouse, their significant other, their parents, whatever. But we understand what it means to have cancer diagnosis, what it means to go through cancer treatment, and maybe even more importantly, what it means to have survived cancer, which in some ways is the most difficult, part of the whole journey, as we call it. So there are really two main components of the Patient Advisory Committee: research advocates and community advocates. We've had the research advocates for quite some time. And when I started here 5 years ago, we had a full cadre of research advocates. But the problem is that they didn't really represent the full range of patients that we do end up seeing. And the question came up, well, how do we change that? And how do we get more people? Because we're experienced in clinical studies and helping support the various committees in developing and designing clinical studies, but we don't necessarily represent all the patients that are going through the cancer treatment. But we do have lived experience, so we do try to represent that and help you make your trials and your proposals to NCI more meaningful. And I've been thinking, actually, with the FDA's patient-focused drug development, the fact that Conquer Cancer now has a patient, needs to have a patient involved in the development of their proposals and applications for Young Investigator Awards, for example. I think over the next few years, if you don't have patients involved in your study, in your application, in your proposal, you're probably not going to get funded. So I think it's really important, and I think people here at SWOG will have an advantage because you deal with it all the time. We're involved in the design of all the studies through the various committees. So again, so every committee has a research advocate assigned to it. I'm assigned here to survivorship. And that's really important because we can help develop the protocols, but the community advocates represent a number of different communities that may be very important for the study that you're designing. So if you're designing a study that deals with, say, seniors, well, I'm one, but I don't really have a community. I don't deal with the community of senior citizens, no matter what I am. I am a metastatic survivor, but I don't deal with the community of metastatic survivors. I focus on clinical research, working on IRBs, participating in studies and trials, reviewing applications and proposals. But we realized we needed to have people that really could represent the various communities that are important to all of our studies. And I'll go into a little bit more who these community advocates are in a minute. So again, I've already talked about the fact that research advocates understand the clinical process, and we can help you design and develop your proposals, help you run the studies, help you look at how to get patients enrolled if you're having trouble with enrollment, how to get people from dropping out. And we certainly believe that having patients involved in the design of the trials will improve the speed of recruitment and will reduce the turnover and people dropping out of the trials. But as I said, we didn't really understand and represent all the various communities that our patients are members of. And so we brought in these community advocates. So there are 20 research advocates embedded really in all the committees, maybe a couple that I think like radiology maybe doesn't have one, but certainly all the disease committees, and most of the non-disease related communities like survivorship. So community advocates, we have 5 on board. I know some of them had been here, but I guess they've heard this before they knew who they are. So representing adolescents and young adults, LGBTQ+, Latinx and Hispanic, older adults, military veterans. Now, we are still recruiting for 5 additional community advocates, caregivers, metastatic, African American, rural, and Asian American and Pacific Islanders, even though, as I said, so I'm metastatic, but I don't focus on that community, I focus on survivorship and colorectal cancer, which is what I did survive. So we are still looking to fill those positions. And we do have some research advocates that are African Americans, but again, they're not representing their community. They're working with their committees to design and implement better studies and better trials. And I think that there was another one, because what I was going to talk about then is how this leads into our focus on DEI, which I'd mentioned earlier on. And because that one got dropped. So one of the things that you probably have been involved with is this team science training. There have been 5 modules, been around for a number of years. Everyone's had to take them. There's now been a 6th module that's been developed, which focuses on DEI. And it started off, just like the first 5 did, that the committee chairs and vice chairs took that training, and we're waiting to roll it out to the entire SWOG research community until we had a new training learning management center in place. And I believe that's taken place now. And if that has, or you'll be informed when that training is available to you. But it really does talk about how you can incorporate DEI concepts into your trials, which will make your trials and studies more useful. I also wanted to mention, probably everyone is aware now that Dr. Dizon has been appointed to be the vice chair for DEI. I've worked with Don 5 years ago when I started here. He was one of the people who worked with the Survivorship Committee, and he had a study that he and I worked on together. So, I've known him for at least those 5 years. I see him on Twitter all the time. He's really great, really understands a lot of things, easy to work with, good communicator. And I really think that that'll be a big plus to help get SWOG really plugged into the DEI world and again, make our studies really fair and equitable. I mean, you heard from Dr. Simon how important that is, but it doesn't just happen. And she can talk about it, still doesn't make it happen. What makes it happen is embedding people and getting people in the organization who are really committed to DEI, both from the top, Dr. Blanke, Dr. Dizon, and from the bottom, community advocates and the research advocates. So that's what I wanted to talk to you about. Maybe things you've heard about before, but hopefully I could add a little more context to it than you've heard before. So thank you.
Thank you. I didn't realize that. Wonderful. Sure. I don't think Justin needs an introduction. He's so well known to our committee, but Justin, and on behalf of Monica as well, is going to update us on your trial. You can. Yeah.
That's fine. All right. Just making sure. All right. And green means go, right? Well, Lee, thanks for being here. And, honestly, as I was thinking about this, I wanted to first start out and just say thanks to the whole team. I see Catherine out there. We really do have a good team working on this study, and a lot of people put in a lot of time. And for people who haven't worked with advocates, I'm fortunate enough to talk to Lee once a month, and usually squares me up on a few things and points me in the right direction. So they're a great resource. If you haven't engaged them, please do. So, all right, so S1501, Monica and I have done this. The reason I'm well known here is because this is a slow accruing trial, and I've been here for a long time trying to push an apple cart uphill. So I am well known here. Any rate, this is a randomized trial looking at women and or men with metastatic breast cancer that are receiving HER2 targeted therapy that are at high risk for cardiac dysfunction, looking at fairly low intensity intervention, carvedilol, to prevent cardiac dysfunction. I'll spend most of my time probably on this slide. As I said, it has been a slow accruing trial. We've had a little increased activity lately, so I'm not sure if it's our efforts or happenstance, but I'll show you the data here in a second. But we are looking for patients with metastatic breast cancer. They need to be starting or continuing on trastuzumab-based HER2 targeted therapy. It's basically really any HER2 targeted therapy that has any form of trastuzumab in it, whether it's single agent trastuzumab, FAM, deruxtecan, trastuzumab, whether it's trastuzumab in an AI, as long as there's some version of trastuzumab that's an eligible regimen. We allow up to 4 lines of therapy. So that's been amended previously. We've included literally every new HER2 targeted drug that's come forward as acceptable in the trial. We allow biosimilars, brain mets are allowed. I think the one thing that I kind of wanted to focus on today was the HER2 low patients. So recently there was data published at ASCO showing that metastatic patients with HER2 low breast cancer benefit from receiving Enhertu, which is one of the eligible regimens. And so I think this really does open up potentially a whole different set of patients that may be eligible for the trial. We're working on I don't even know what it's called, press release or whatever the monthly news flash is that goes out on the trial, just sort of highlighting that for sites to look for those type of patients, because it may be a group of patients that potentially had previously not been eligible, but I believe will. There's going to be a lot more HER2 targeted therapy being used in metastatic breast cancer. And I think for that
Justin,
matter,
was that formally amended in the protocol?
it really doesn't need to be amended.
But I think the eligibility is for HER2 positive disease.
So the eligibility is for metastatic breast cancer patients receiving HER2 targeted therapy.
Okay.
So it actually,
It
as
doesn't
is,
say HER2 even though it says that in the title.
That's right.
Okay.
And so we looked through it closely on several different calls, and I think as is, it's fine. It does not need a study amendment. And
Great.
so that was nice. We've done enough study amendments. So,
Well
yeah.
done, not overwording your eligibility.
Well, and technically these,
Unbending that tree.
there you go. And we unbent the tree. And these are not HER2 negative patients anyways. They are HER2 positive. They're just HER2 low. But the way the study is written, it specifically wrote metastatic breast cancer patients receiving eligible HER2 target therapy. That was not our intent. We didn't know this was coming, but it is what it is. So any rate, so that may be a patient population that increases eligible patients in your site. So keep that in mind. Other than metastatic breast cancer, patients need to have one risk factor for cardiac dysfunction, whether it's prior anthracycline, a borderline ejection fraction, age greater than or equal to 65, elevated BMI, be on some sort of blood pressure medication, have coronary artery disease, AFib, aflutter, or diabetes. And as far as requirements for startup, you can get the protocol from the CTSU site. Section 13 goes over in detail what's required to start up. The really only sort of hurdle, if you will, is credentialing your echo lab. It requires 2 echocardiograms done on breast cancer patients within the last year to be submitted through a platform called AG MedNet that de-identifies this data and transmits it to Monica at University of Michigan to read. That's our core central echo lab. Once you do that successfully, your site's up and running, or your echo lab, I should say, is up and running, credentialed, and you can move forward. We have 167 validated labs across the country, echo labs, and 148 CTSU sites. 113 of those are SWOG. Here's our list of top accruing sites, and just want to say thanks to all sites that have put patients on, whether it's one or whether it's 44 like City of Hope. Thanks for everyone for participating. We appreciate it. We're over a third of the way done. We have 283 patients on. Pre-pandemic, we were cruising around, I don't know, 9 to 13 patients a month, and it basically went to 0 in 2020. And this is basically what it's looked like since. We've put a lot of effort in, and I don't know, maybe we're starting to see some increased accruals. Certainly happy to talk to people after about what we've done. But at any rate, high points, the observation arm was closed. It was a 3-arm trial. We've successfully accrued that, so only randomized patients are allowed now going forward. We do have a champion for the trial and the Alliance Committee, Dr. Ruddy, and one of our translational aims has been completed. We've actually ran and assayed the baseline neuregulin levels. So we are actively recruiting sites. So if it's not open at your site, look us up, S1501 question@swog.org. If you have any questions, get the protocol off CTSU website, and we would love to have you participate. And here, for those that are interested in dollars and cents, is a copy of the funding memo. And I think that's all I have. So any questions? Thanks for the time, and thanks again to everyone on the team that's helped. It's been a labor of love.
Thank you so much. And next, I wanted to, I think, invite Nicole Kuderer to talk about the iCheckIt study.
Such a pleasure. Thank you so much for having us. We hope to not be too recurring at these meetings. Accrual has been quite encouraging already, you will see. And I'm presenting for Dr. Gunturo, who has been presenting at another meeting. We started off together designing the iCheckIt, and because of competing events and family health issues, I was fantastic that she took over the leadership and heralding the team together, which is great. And here just the study schema to remind everyone. It looks very complicated, but we tried, and thanks to Dawn, Dr. Hirschman, really got it quite concise, and most of the heavy lifting is actually done by the patients. But please give us feedback, or the study chairs, if you don't want to talk to us directly. We appreciate anything you can help us further improve the experience for the study sites. Really, it's after consenting and baseline evaluation. There are really only 4 major time points after that. It's at the week 4, and that is to get at the impact of therapy, how therapy changes biomarkers as well as PROs and quality of life, of course. And then beyond that, really it's only the patient assessment, no more major biomarker assessment at 12, 24, and 52 weeks, except for when they have a grade 3 or greater IRE event. And I just want to be sure we do require the completion of full 1 year. This is a study where the patient does not come off study when they progress. We do want to assess them for that full year, as this is a toxicity study. So the objective is really to develop an independently validated risk prediction model for CDC-AE grade 3 or higher non-hematologic immune-related adverse events. And that is during the full first year of immunotherapy, checkpoint inhibitor therapy for solid tumors. And this has been a wonderful effort, team effort, to really help us risk predict, find both clinical and molecular predictors, who is at risk for these serious adverse events that are really the next frontier to febrile neutropenia and other serious fatal events that are challenging the medical community and especially patients. And as many of you know, these can be quite devastating and can happen quite quickly, as we heard this morning again from Dr. Conturo, and we see regularly at multidisciplinary tumor boards, if you will, for IRAEs, that these events are very challenging. So these are the secondary objectives. I don't want to bore you too much, but we also, again, important here is the longitudinal assessment of toxicities, as well as lower grade toxicities in patient-reported outcomes and quality of life, and especially also biomarkers and a biorepository to get at the molecular aspects as well. Accrual goal, we are over 2,000 patients, or just about 2,000 patients, and we are already at 22%. We are quite excited about this in the first year. Accrual has been about 50 to 60 patients now per month. We hope we stay this way. And this is again, despite also having blood and tissue collected. The tissue is optional, but we have been grateful that many have already provided optional tumor tissue as well, and we hope to obtain even more than this. And thanks to the top accruers, and the big part of the CHI are sites that have a few patients each, so there are many more sites that are accruing. This is the study calendar, again, not to belabor this and not to scare you again. It looks like a lot of detail. Most of this are patient PROs and quality of life measures. I just wanted to remind you, we're also trying to collect, it's not required, but again, highly encouraged, TSH, cortisol, magnesium, and ACTH. We don't even know these basic markers that there's a good chance that they're correlated with future IRAE events, especially if they have a family history or personal history of autoimmune disease. And we don't even know these basics of these simple blood biomarkers, if they might help us predict who's most vulnerable. And again, translational objective is, first of all, to evaluate a known cytokine, the cytotox score, which is a composite measure derived from 11 different cytokines. Might this be predictive? Can we validate this score that has been proposed? But most importantly, as this is a rapidly evolving field, are we creating a biorepository of archival tissue, and especially blood and plasma, as well as whole blood? And now we're adding the microbiome, which you will hear briefly about. And the translational microbiome that has been is under review and looks very encouraging. We'll look at the baseline microbiome composition and metabolomics with the risk associated with the risk of severe IRAE, as well as to evaluate the changes over time. And again, might they help us to understand who develops a severe IRAE? Again, the same time points as for blood, that's a baseline at week 4 to 6. We allow a fudge factor for that time point, as well as upon the onset of grade 3 or greater IRAEs. There's also pharmacoeconomic analysis that's just been added to assess, from South America actually, to assess kilo-based prescription versus fixed dose population, the economic impact, as well as might those factors also maybe help us help predict IRAEs. And that's the study team, wonderful. It's been an incredible experience with just fantastic people overall, including our patient advocates, not to forget Amy Schwender and Anna Marie McCurry, who's been a wonderful stand-in as well. Thank you. Thank you.
Thank you, Nicole. Okay, I think, yep. Next we have Dr. Raz and Dr. Sun to present their concept and next steps.
Okay, thank you. So Virginia is the study co-chair. I'm Dan Raz. I'm a thoracic surgeon from City of Hope. I've met some of you, but not all of you. This is our study scheme. I'll introduce the purpose of the study. So this is an perioperative home telephone-based exercise program for older adults who are undergoing lung cancer surgery. And the reason this is important is obviously exercise is important for recovery from many surgeries throughout the cancer continuum, for health in general, but lung cancer surgery is unique in that, number one, We are physically removing parts of lung tissue from people who are already somewhat compromised, oftentimes from a breathing perspective. Lung surgery hurts. Even with minimally invasive surgery, the ribs are a very sensitive part of the body, and it can kind of compound not wanting to get up and walk. And then to top everything off, lung cancer tends to occur in people who are older, more physically frail. And so oftentimes what can happen is people after surgery, can't breathe too well, they hurt, they just don't feel like walking, and that can kind of spiral into becoming more and more deconditioned. So as a thoracic surgeon, encouraging people to get up and walk after surgery is just part of the job. There have been several studies trying to find ways to have programs to get people up and walking, but unfortunately they're not really utilized for a variety of reasons that I won't get into. And so I think this is a really kind of innovative approach where we are randomizing lung cancer patients who are 65 years and older, but also their family caregivers. So they're going to be involved as well. The patients undergo a baseline assessment, which includes a geriatric assessment. They have a 6-minute walk test, SPPB for the kind of functional standpoint. Then they get randomized to either the intervention arm or a control. So the intervention is a personalized walking and lower extremity exercise program that's delivered centrally via telephone at City of Hope from PT/OT interventionists. And that's delivered to both the patient and the family caregiver, who's trained to support and coach the patient and serve as a walking buddy with the patient. The patients also get a pedometer, a VivaFit 4, and a resource manual. And in the control arm, they basically get a pedometer and some information, but that's about all. And I apologize, this is an old schema, so I think the schemas got mixed up, but we have an additional time point. So they get assessed at discharge, 30 days, 60 days, and at 180 days with 6-minute walk test, SPPB, and quality of life surveys. You can look at that green rectangle below that shows the different outcome measures that we have. Oh, I guess that's all I thought I had a where we're at slide.
Sorry. You seem to have dropped a few slides somehow.
Yeah, I think some of the slides got
Sorry,
dropped. So our primary endpoint is change in 6-minute walk test, but we have a number of other endpoints that we're looking at. Where we're at currently is that we were funded via PCORI through the Healthy Aging, thank you, Healthy Aging mechanism, so it's very exciting. We did submit an R01, which was scored, but was not a fundable score. And we're currently going through the NCI DCP approval process, which is taking a little bit longer than we initially anticipated, but that's where we're at. According to our current timeline, funding will start in January, and we're hoping to start enrolling in August 2023. So I want to thank everyone for getting us to where we are now, particularly Virginia for navigating through this program, Haley and Melinda, Dawn, and Lee. Lee has been great. Thank you very much for helping us bring the patient perspective into this as well, which was really critical, especially for this PCORI grant and some of the additional endpoints that we put into that grant. So thank you.
Thank you.
Yes.
So for the 6-minute walk, is that done at the clinic site or is that done remotely?
Yes, it is done in the clinic site.
Okay, and then since a lot of these patients won't be coming into the oncology clinic, and a lot of like NCORE sites being in the community, we don't see these patients. We don't have a good way of getting those. So are you guys going to develop material to give to the surgeons to help advertise the study?
Yeah, so I mean, I am a surgeon, and we have already 11 sites, 11 surgeons who've kind of committed to the study, which is great. And I'm definitely going to be actively engaging surgeons to both community and academic to participate in this. So yes, idea is that this is primarily done kind of in the surgical side.
Okay,
Yeah.
thank you.
Just real quick, one more question. What's been your pilot experience with the 6-minute walk, and how much of a bump do you expect with the exercise in the intervention group?
Great question. So we piloted this intervention, and in that pilot, we didn't have a control group. So, we just had the intervention group, and we actually had modest improvements in 6-minute walk test at 2 to 4 weeks. We had kind of had a range in endpoint, which is actually, compared to other trials I've done, traditionally there's a pretty steep drop off that happens during that time period post-operatively. So, we were very encouraged by that finding.
The net difference
Net
between
difference.
groups will be quite
Right,
more than just an increase from 0.
right. Thank you.
Thank you. We're very excited to get that up and running. And then we're going to need a little help from our IT team here to try to get we have a couple of remote speakers who are presenting from home. Vicki Barricos is going to share an update on her work on a correlative study of SWOG 0816, looking at predictors of muscle wasting. Vicki, are you able to speak? Does she have ability? You need to unmute your mic, apparently. And so are you able to see whether she's physically on? Baracos. She sent us a few slides, and I'm gonna, okay, so I think we'll move on. This Chetan Ramamurthy is on, and hopefully we'll have the ability to present a newer concept. We heard this presented at one of our phone calls, but now wanted to have the opportunity to present at this group as well. And this is a phase 2 randomized controlled trial of vortioxetine to reduce androgen deprivation therapy induced cognitive impairment. I'll turn it over to you, Dr. Ramamurthy.
Hi.
Yes.
Hope you guys can hear me. Great.
Yes.
All right. I hear myself echoing. Yes, my apologies for not being able to be there in person, and grateful for the opportunity to present this concept and develop it with this amazing group. And thanks to all of the prior speakers as well. Next slide, please. So I am a genitourinary medical oncologist. I practice in San Antonio, Texas at University of Texas Health San Antonio, Mays Cancer Center. And I see a lot of patients who receive androgen deprivation therapy as it remains the backbone of systemic treatment for prostate cancer. And we know that nearly half of men with prostate cancer at some point in their disease course will receive androgen deprivation therapy. And it is extremely effective as a treatment and treatment backbone for the treatment of various stages of prostate cancer. But we do know that it can have detrimental neurocognitive effects. There's a lot of research that has elucidated some of the reasons for this. We know that testosterone can be neuroprotective and can prevent beta amyloid deposition, which we know is implicated in the development of Alzheimer's dementia. We know from large cohort studies that those who have received androgen deprivation therapy are at an increased risk of developing any cause dementia compared to those who have not received androgen deprivation therapy. Yet there are very few prospective longitudinal studies that have really rigorously studied the cognitive effects of androgen deprivation therapy. So it's in this context that some of my neuroscience colleagues here at UT Health have been collaborating with us to look at ways that we can model the cognitive effects of androgen deprivation therapy and ways that we can potentially reverse or treat androgen deprivation therapy induced cognitive impairment. And it's through that work that we have been studying this drug vortioxetine, which is a novel multimodal antidepressant that actually has specific labeling regarding improved cognitive function in depression, which is pretty unique among all of the different antidepressants that are available. So they've generated some excellent preclinical data for us. We know that castration induces deficits in the medial prefrontal cortex, as well as the hippocampus. That's demonstrated here in terms of the set shifting test, as well as the novel object location task that you see. In those who undergo castration, there are clear deficits to both of these different measures. And you can see that vortioxetine essentially restores the function in these rats on these markers of cognitive dysfunction. And we have clinical experience conducting extensive neuropsychological evaluation in men undergoing androgen deprivation therapy. And actually, quite interestingly, about 50% of patients who we tested met criteria for mild cognitive impairment. Many carried these ApoE4 alleles that can predict risk of Alzheimer's disease. And we've also been piloting using some tablet-based neurocognitive tests that we propose to use in this trial. Next slide. So the goals of this study are, one, to look at vortioxetine's efficacy and safety in reducing cognitive impairment associated with ADT in prostate cancer patients. And second, to explore genetic biomarkers predictive of cognitive decline in men treated with ADT for prostate cancer. And that includes the ApoE allele, their polygenic risk scores that have been developed for Alzheimer's disease, and some single nucleotide polymorphisms that have been identified in prior studies of ADT-related cognitive decline that could be interesting to investigate as well. Next slide. So it's a pretty simple study in terms of its design. The key inclusion criteria are men who are planned to receive greater than or equal to 1 year of continuous ADT. That includes patients who are treated in the localized disease setting with radiation therapy, for example, and will be receiving 2 to 3 years of adjuvant androgen deprivation therapy. Men with biochemical recurrence who are treated with androgen deprivation therapy, and various other disease sites that are treated with ADT for 1 year or longer. And then the key exclusion criteria are people who have known dementia or mild cognitive impairment. We will be doing a mini cog assessment, which is just a very quick 3-question survey that is administered to the patients to exclude patients who have frank dementia, and then also excluding those who are on additional novel hormonal agents such as enzalutamide or abiraterone, or any of the newer agents such as darolutamide, because of the potential confounds that those agents could pose. I will note that because of the sort of changing treatment landscape, the plan is to exclude patients who are planned to receive those in the upfront setting, but if they do receive them later on in their disease course, even if it's during the 1 year of treatment, that they could still continue on the study so that we can gain some information on those patients as well. And essentially, patients would then be randomized, if we could go back to that slide, patients would then be randomized to either receive vortioxetine for 1 year or placebo for a year. We do have support from the company that makes the drug to provide both drug and placebo to us. And the efficacy of vortioxetine would be measured using tablet-based neurocognitive assessments, primarily the CAN-TAB, which I'll go into in a little bit more detail, as well as multiple patient-reported outcomes, both surrounding cognition as well as general quality of life, depression, and anxiety. And I think that's actually really quite useful because there are not great longitudinal studies that have looked at the effects of androgen deprivation therapy on depression and anxiety in the context of treatment with an SSRI. And the co-primary endpoints of the study will be two of this CAN-TAB based cognitive metrics. I'll go to the next slide, please. So the CAN-TAB is a tablet-based neurocognitive assessment. It's available in over 50 different languages. It's validated, used in prior registrational studies for medications that have been approved for various neurocognitive indications. Chose it because it's portable. It has multiple methods of administration. You can give it on a tablet in person. It can also be delivered via email to patients to complete on their own. People don't really need to have extensive training in order to administer it. We've been able to give it to trained college graduates who don't have very much additional research training or any sort of neurocognitive study background. And these CAN-TAB tests, of which we plan to use as our primary metrics, two of these, they directly correlate with the studies that vortioxetine has demonstrated a benefit in and that ADT has demonstrated the most deficit in. And that is in visuospatial memory as well as executive function. Next slide. So the primary hypothesis is that those receiving ADT will have an improved cognitive function relative to baseline when treated with vortioxetine at 12 months compared to those receiving placebo. And the co-primary endpoints will be the CAN-TAB PAL test, which is a measure of visuospatial memory primarily, and has the highest correlation with mild cognitive impairment and dementia, and so is very clinically meaningful, as well as the CAN-TAB IED, which is a measure of executive function and is an exquisite test for executive function in the medial prefrontal cortex. And this is something that we've been discussing since we had our call last month in terms of the best approach to this study, originally designed as a randomized phase 2 study. And with 110 completers, this was able to achieve a power of 82% with an effect size of 0.55. But we've discussed making this into a larger trial to be a little bit more definitive in terms of the conclusions as well. Next slide. I think that's it.
Yeah, so we'd love to have, since this is a newer concept, some feedback from those in the audience, including those online.
I'd like to make sure that he sends me a copy of it. This is Lee Jones, I'm the advocate, so I can get a chance to review it, and at some point I'll have to help present it to executive committee for approval when we reach that point. So the sooner you can get it to me, it's lee-jones@verizon.net, the better.
Actually, this is Catherine Guthrie, our statistician. We actually don't have a capsule yet to review. I look forward to receiving that capsule also and to helping you redesign this to be a larger study. Please, well, I'll reach out to you by email, but let me know how I can help.
So has there, I thought the one page was done and then it came to us after that was done. Was that how, where do things stand in terms of the development?
I think that Taj sent out a template and I have not received anything back. I think Taj sort of connected us. So I'm looking forward to receiving the what's called the capsule form, which is sometimes called a 10-pager, but it doesn't have to be 10 pages. It could be 5.
Right. So we're waiting for that next a little bit more, with more elaboration than just
Yeah,
your
and then where
original
we
one-pager.
actually like work out sample size and the design and all those aspects. So, yep.
Got it.
It might be just helpful just to have a small call to go through what, with Catherine and maybe with Lee and everybody, just as opposed to like just, working on things independently, just to sort of come together, have a call, discuss what needs to be done, set up a timeline. Because I find that that's probably the best way, just because otherwise it'll be 6 months and you'll be in the same place. So maybe just pulling the chairs and Lee, Catherine and Virginia together and just sort of saying like, what needs to get done? What are the how do we make this? I think with SWOG, we have a little bit more, we have the ability to have a larger study, to have it be more definitive. If you're going to put all this work into it, have it be a bigger study to really answer the question, figure out what the most important primary endpoint is, to redo the sample size calculation so that you can get the concept written.
Yeah, and I think as we are moving toward like every other month or even every third month, whole committee meetings, we might be able to use that time slot for some of these smaller meetings. Yeah. All right, and then we just have a couple of studies that we're working on with other cooperative groups, and Melinda's gonna just
So
announce this one.
hopefully Allison Grimes is still on the call, and we're going to jump you right to your schema and have you share with us your study and then any updates, just because we're a little bit
Very brief.
late in the session.
No problem. This will be quick, so I'll catch you up. For those that don't know me, I'm Allison Grimes. I'm a pediatric oncologist and director the Adolescent Young Adult Cancer Program at UT Health San Antonio. And you have, I believe, heard this concept previously from the SWOG champion, Stephanie Tsai. So I'm just going to review the schema here for use of continuous glucose monitoring early in ALL therapy in older children, adolescents, and young adults. We would be targeting patients that have both B and T cell ALL at the time of diagnosis, just prior to the receipt of the first asparaginase. Age as young as 10, as old as 39 at the time of enrollment. The induction phase would need to include high-dose steroids for at least 14 days. Patients would be randomized to receive one of two types of continuous glucose monitors, a blinded device, which would be the control arm, patients that are otherwise receiving standard of care, and an unblinded device, which is a continuous glucose monitor used just like a diabetic patient would use it. There's a total of a 12-week reporting period, so that's the 6-week wear period, plus 6 additional weeks after the wear period, mostly per reporting of infectious outcomes. So patients are randomized, oh, if you can go back one, sorry, right at the time of enrollment to either arm. The CGM is placed just after the time of randomization. Those that have the blinded CGM just change out the sensors every 7 to 10 days. And then that data is reviewed at the end, so not available in real time. The patients that have the unblinded devices are seeing, using, interacting with that data. They have alarms set for highs and lows. Their providers and their endocrinologist that may be involved, if they have some extreme highs and lows, are responding to that data and managing the patient. Those patients are also using the paired Dexcom Clarity app, which allows real-time viewing of those Q5-minute glucose measurements by the patient, any approved contacts, and the healthcare team. Next slide. This concept, we have revised our stats, and we are trying to update a couple of statistics to make sure that we're going to be able to include the adult population of patients that receive a total of 14 days of steroids, but those days are split. For example, the pulse interrupted dexamethasone, just as we would include the patients with 28 continuous days of prednisone or 14 continuous days of steroids. We are working on funding resubmission, since we do need funding for the devices and supplies for this study. And we have completed and will be sending out again for increased input a survey of adult providers and current practices related to hyperglycemia and steroids and induction. And then that same survey is going to go out through our pediatric network as well. I'm happy to take any questions.
Right, and I'm going to just ask that maybe you could put your email in the chat, and people who could contact you directly if they have questions or input for this. So thank you very much, and sorry to rush through, but we're a little bit over time. I think we don't really need to do the liaison updates. We didn't receive any pressing issues from those groups. And then the last study that we've been involved with is this GnRH analog for protecting ovarian reserve in AYA young adult, or in AYA adults with cancer. And we basically are, the development is on hold while we wait to hear about a DoD grant that was submitted. So waiting to hear about funding on that. So more to come. Apologize for going over, everybody. Thank you so much for your attention.